So welcome everyone. My name is Mina Nabavi, and I'm a program director with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. I'm excited to welcome you to today's webinar, an update on childhood vaccines, getting ready for the school year, featuring Dr. David Kimberlin from the University of Alabama at Birmingham. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control, Training and Technical Assistance, or ARC-IPC. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past webinars and podcasts, sign up for our newsletter, request training and technical assistance, and view infection prevention and control resources at uab.edu/ARC-IPC. You can also email arcipc@uab.edu. We would like to thank our co-sponsors for today's webinar, the Deep South Center for Occupational Health and Safety and the Region 4 Public Health Training Center. You can learn more about their programs and the centers as a whole at their websites listed on this screen. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must register for the training, watch the entire program, complete the evaluation following the program, and upon completion of the evaluation, you will be redirected to the Alabama Nursing CEU request form, which you will also need to complete. CEUs will be awarded by the Deep South Center for Occupational Health and Safety. You do not have to submit directly to the Alabama Board of Nursing. CE units for this program will expire on July 13th, 2024. If you experience any issues, please email arcipc@uab.edu. We will place this email in the chat box as well. And finally, it's my pleasure to introduce our speaker. Dr. David Kimberlin is the Sergio Stagno, MD, Endowed Chair in Infectious Diseases, Professor and Co-Division Director in the Division of Pediatric Infectious Diseases at UAB. He is also the Vice Chair for Clinical and Translational Research with UAB Pediatrics. He is the editor of the American Academy of Pediatrics Red Book Report of Committee on Infectious Disease and the AAP liaison to the Centers for Disease Control and Prevention Advisory Committee on Immunization Practices, or ACIP. Dr. Kimberlin has also been involved in the national efforts relating to COVID vaccinations in children and adolescents. And Dr. Kimberlin has recorded several podcasts for the ARC-IPC, and so we are very pleased to have him to present this webinar today. So without further ado, it's my pleasure to turn things over to Dr. Kimberlin.
Well, I appreciate the opportunity to be with you today. I always love talking about vaccines and about immunization programs, and I think as we are approaching school, that's always a time year after year where we can think about it again. We can see what kind of progress we've made, what kind of challenges lie ahead. And so I'm hoping that these next 45 minutes or so will begin to provide some of that perspective to you as you go about your daily work with the patients that you take care of, or your children if you're a parent listening to this. In terms of disclosures, I always indicate that I intend to discuss products that are off-label because so much in pediatrics is. I'm not real sure that the vaccines actually are, but it is something I always cover just in case. I do have, all of my research is NIH funded. I do have one relevant commercial relationship to disclose. It's a completed study that Gilead did of remdesivir during the pandemic. I was the site principal investigator for that. And all monies went straight to UAB and not to me. That study is now over. And we're not going to be talking about COVID vaccines unless it comes up in the Q&A. It's certainly not treatment of COVID, so it doesn't really impact this particular presentation. What I show on this slide is something that you're very familiar with, and this is the annual vaccine schedule. for children. They have a counterpart for adults. They have another counterpart for catch-up immunization. But I put this out there as the image because it's complex. If you back up 30 years, we didn't have nearly as many rows on this. So that adds challenges because the complexity is something that can be a little overwhelming at times. On the other hand, think about how many more diseases we also are impacting, preventing, and how many lives are being saved as a consequence. It's a good problem to have, in other words. Every year, the Centers for Disease Control and Prevention, in collaboration with the American Academy of Pediatrics, the American Academy of Family Practice, and the American College of Obstetrics and Gynecology, or ACOG, puts together this particular vaccine schedule. They add new vaccines to the schedule. Occasionally, if the vaccine's fallen off, they'll take it away. But mostly, they work on the visualization of it to try to make it an easy type of a tool that can be used at patient care to determine what is needed in the columns at a given clinical visit for follow-up and well-child checks, well-child visits. What you see in yellow are the recommended vaccines for all ages through 18 years of age that's represented on this table. In green are catch-up recommendations. In purple are high-risk group recommendations. So it doesn't apply to everybody, but if you're in a high-risk group, as defined in the notes page, which goes on for a long time, I'm not going to show that. Then you can see at least where you might need to consider, for example, meningococcal vaccine as an example. And then you can see the other color codes and stippled kind of boxes in the lower part as well. We're having a problem with vaccine uptake around the country. If you look at the final bullet on this slide, during the 2019 to 2020 period to the 2021-2022 period, overall vaccine coverage rates dropped a full percentage point. We, looking at the MMR vaccine, are at a national, in 2021-2022, a national rate of 93%, which is below the 2030 target. We want to be at 95% or above, and that is achieved in only 15 states. Now, I do have here an arrow of where Alabama is. And so many times, as we all know, Alabama is either at the top of the wrong list or the bottom of the right list. In this case, we do quite well, actually, compared with our counterparts around the other states around the country. And if you look, this is specifically at MMR coverage and not up to date without exemptions, darker blue, lighter blue, respectively. And you follow the line on across, we are about at 95% vaccine uptake for MMR, which is, again, something that we should be, and I think are, quite proud of. Drilling down specifically at the national estimates and the medians thereof, and then specifically looking at the row for Alabama, you can see that looking at the population of children, 2 MMR doses nationally is around 93%. We are at or above 95%. 5 doses of DTaP in the 92 to 93% range. Again, we exceed 95%. You can see your way all the way across here. The important numbers for us here in Alabama is this bottom middle portion of the bottom row. And that's showing that we're doing, y'all are doing, parents are doing, families are doing a really good job with this. We don't still, need to just sit back on our laurels, because there's a lot of, as we all know, chatter in the social media realm and sphere and so forth, where at any moment we could lose ground with respect to our vaccination records and the accomplishments thereof. But for right now, we are in a good spot, especially relative to so many other states. Now, it's not evenly distributed, and this is not a surprise to any of us. There are health disparities at play here. And what's shown on this particular image or table is the private insurance, and I put red boxes around, for instance, the 7 combined vaccine series. About 78% of people with private insurance are, by the time they're 24 months of age, have received all of those. And if you look, and this is national, and you look at the Medicaid population, it's 66% or so, and among uninsured populations, 48%. So while we have much to be proud of, we also have a lot of work to do, because until everyone is protected, then we're all at risk. Now let me move into some specifics, and this is where I'm trying to highlight some new developments that have already occurred, let's say in the past year or so, but also things that are on the immediate horizon, things that I think will impact your daily clinical care pathways and paradigms as we move forward, but we're not quite there yet. Now, one of the things where we are there is the approval recently in this past calendar year of a second MMR vaccine. As you all know, Merck makes MMR2 and makes MMRV, which is the measles, mumps, rubella 3-valent vaccine, or the quadrivalent MMRV, where V adds in the varicella component. But now we have a GSK product as well called Priorix. This is a vaccine that's been used now for 26 years in Europe. Over 400 million doses have been distributed. It is immunologically non-inferior to the current vaccine that has the same safety profile as well. And now that we have two manufacturers, we've got a couple of opportunities here. One is to have a decreased likelihood of a disruption in supply. It's always better to have two or more suppliers than to have a single supplier. In addition, now that there's some competition in the marketplace, maybe we'll see some decreasing in the prices. Now, MMR is not one of the more pricey vaccines compared with some of the other newer ones, but nevertheless, it's always good to have some competition in the marketplace as well. Now, these two vaccines are so similar that they can also be used interchangeably. If you've already started MMR2 and you've got Priorix in your office, for example, you can simply, at the 4 to 6 year age recommendation for the second MMR, use Priorix in that example instead of MMR2. You can stay with the same one all the way through. But to know that you've got interchangeability gives you flexibility. This table shows the different components of the measles Edmondson strain in MMR2, the Gerald Lynn strain for mumps in MMR2, and the Y-Star rubella strain for the 27.3 rubella strain for MMR2, and what the corresponding equivalents in Priorix are. The rubella strain is the exact same, and then we have a Schwartz strain for measles and RIT 4385 for mumps. But looking at it at the nucleotide level, these are identical vaccines. So it's something that reinforces the interchangeability thereof. Let's change now to where we have a lot of developments, and this is in pneumococcal vaccines. We, a year ago, if I'd been doing this talk, would have had, or maybe a little bit more than a year ago, we would have only had the PCV13 conjugate pneumococcal vaccine to talk about, and PPSV23, the polysaccharide vaccine that's used in a risk-based kind of fashion. But over the last year, we initially first had PCV15 added, and now, very recently, we've had PCV20 come available for use in children. And you can see that for 13, 15, and 20, they're all recommended for children, and for adults, both 15 and 20 are recommended. I'm only going to be talking about pediatric utilization of both PCV15 and PCV20 over these next few minutes. This is an image that shows, and I find it to be a very useful graphic. It shows the 13 serotypes in yellow that are in PCV13. And then PCV15 contains all of PCV13 plus 22F and 33F. And then PCV20 contains everything that PCV15 had, plus 8, 10A, 11A, 12F, and 15B. And this is compared with the old vaccine, the PPSV23 polysaccharide vaccine, that has everything that 13, well, I guess I'll say this, it has everything that 20 has, which then has 15 and 13, except for 6A. And then PPSV23 also has these additional 4 serotypes that are in there. So this is, I think, and you'll have access to a PDF of all these slides. If you want to email me, I'd send you the PowerPoint to them as well. If you want to use them for your own purposes, your own presentations and so forth. But I really like this image because it makes it easier for me to remember how 15 relates to 13, how 20 relates to 15 and 13, and so forth. The vaccine recommendations for children under 2 years of age remain a 3+1 schedule, a 3-dose primary series followed by 1 boost. That primary series is at 2, 4, and 6 months. And then the boost is at 12 to 15 months. And this is going to be the case, as we'll see on subsequent slides, for PCV 20, PCV 15, or PCV 13, although 13 is going to go away now that now that 20 is on the market because they're manufactured by the same company. I'm going to show you some data slides here because I think they're going to be relevant. And if nothing else, you're going to have marketers come into your offices and they're going to stress different aspects of the data for PCV 15 and PCV 20. But I think it's important for y'all to see the data directly. And this is from the ACIP meeting. Many of the slides I'm going to be showing here. ACIP meeting, in this case, it's February 2022. And I'll try to point out on subsequent slides what ACIP meeting these data are being pulled from. So this is a non-inferiority assessment of predefined levels of IgG against the different serotypes post-dose 3. So following dose 3 prior to the booster. And you can see that for each of the serotypes that were tested, where there's a 15 and a 13 that can be compared, 15 was non-inferior to 13 in terms of serologic response for that given serotype. So that's one of the emphasis areas where you're going to be hearing differences from companies, and it's specifically about, you're going to hear a lot from the manufacturer of PCV 15 about this serotype 3. And the reason for that is from this slide. This is a slide of non-inferiority assessments following dose 3 of PCV 20 versus PCV 13. You want to be on in this case, the right-hand side of the dotted line, and you don't want to touch or cross the dotted line. That if you achieve that, then you've achieved non-inferiority. And you can see that of the shared strains, the shared serotypes in 13 and 20, there are 5 instances where the non-inferiority following dose 3 was not met with PCV 20. Maybe the one that gets the most attention is this PCV 3 serologic response following dose 3, because serotype 3 is causing a fair amount of pneumococcal disease these days in the post PCV 13 era. Now, that said, if you look at the same non-inferiority type of assessment, but following dose 4, everything is to the right. Each of these 13 are to the right of the dotted line. So if this has clinical meaning, clinical impact, and we don't know if it does, we don't know if it does, it would be during that window of time between the 6-month dose and the 12 to 15-month dose, if it does. And I'll also mention that PCV 13 had failed to meet non-inferiority for some of the serotypes that were different between the older PCV 7 and PCV 13. And so there was much of the same hand-wringing when PCV 13 rolled out. Clinically, in that example, it never correlated with a change in the clinical benefit or the clinical effectiveness or efficacy of these vaccines. This was a slide from June 2023, the meeting that just took place at the ACIP just last month. And what it looks at is these are raw numbers that are in the second column, the column on the right. It's looking at the number of cases, or well, I guess cases really, for each of these rows. If you swapped PCV 20 for PCV 13, so instead it is, for example, if you use all PCV 20 and no PCV 15, you would have 25 fewer cases of pneumococcal meningitis, 125 fewer cases of non-meningitis invasive pneumococcal disease, 500 fewer cases of inpatient pneumonia, about 825 fewer cases of outpatient pneumonia, and you can work your way on down, over 100,000 fewer episodes of acute otitis media, close to 11,000 fewer PE tubes placed, and you'd see 7 fewer deaths for invasive disease and 4 fewer deaths for pneumonia. This is among healthy children. So it shows that at least in the modeling that's done, there may be benefit of having a larger number after the letters PCV, and it kind of makes sense. If we're covering more serotypes and if the immune response is adequate, then you might have a better clinical impact societally if you use PCV20 instead of PCV15. So all this leads to the next series of slides, which are going to be recitations of the ACIP votes that took place at the end of June 2023. And there are 4 votes that took place. The first one was concerning routine PCV, pneumococcal conjugate vaccine use for children under 24 months of age. There is not a preference. Use of either PCV15 or PCV20 is recommended for children aged 2 through 23 months, according to the currently recommended pneumococcal conjugate vaccine dosing and schedules. They did not take a preference for 20 over 15 or vice versa. They, in their judgment, wanted to see what the clinical impact was as these 2 vaccines roll out in parallel with one another. PCV15 has already been out for a few months, but PCV20 will take a little time to ramp up. But let's see where it goes from the standpoint of once they're both being used in the field. Let's let the market as well drive things. And it's always good, as I've said before, with respect to measles, mumps, rubella, it's good to have redundancy in manufacturing. Now I'm going to show you what this looks like in a table. This was also from the ACIP meeting, and it looks at the 2 through 6 month olds, the 7 through 12 month olds, the 12 through 11 month olds rather, the 12 through 23 month olds, whether they'd had one prior dose of 13, 15, or 20, 2 prior doses, or 3 prior doses, and then what the regimen recommendations will be. So this will be hopefully shown in this kind of a graphic form when the MMWR comes out. I'm already working to update the 2021 Red Book chapter that's available in Red Book Online, so that as soon as the MMWR goes live, that the AAP can harmonize with that with an updated pneumococcal chapter for the 2021 edition. And of course, we're building it in as well to the 2024 Red Book, which will come out at the end of April of next year. And then for the older age groups, again, how many doses they had and when those doses were in terms of how to respond with additional PCV15 or 20 administration. Now, the next vote taken at the June meeting was on catch-up pneumococcal conjugate vaccine doses for children who were 12 through 71 months of age. So if you have children with an incomplete pneumococcal vaccination status, use of either 15 or 20, according to currently recommended dosing and schedule recommendations, is recommended for healthy children ages 24 through 59 months. And if a child has specific risk conditions, I'll show on the next slide, it's recommended for not just through 59 months, but actually through 71 months. So again, no preference. And this is simply adding PCV20 and taking away PCV13 in terms of what the recommendations are. Now, there has been a modest increase in the categorization of what is a risk group or a condition. And what's highlighted in yellow here illustrates the differences compared with what we currently have. And this was done to harmonize with the adult pneumococcal conjugate vaccine recommendations. So when they've added chronic kidney disease, chronic liver disease, maintenance dialysis, the one that probably is going to impact pediatric care most is for the definition of chronic lung disease. It now includes moderate persistent or severe persistent asthma. That is a risk factor that then will impact your recommendations to give the pneumococcal conjugate vaccine. And this is a similar kind of table to what I showed following the vote number 1. Healthy children by age, children with risk factors, number of prior doses, and then the recommendations for either 15 or 20. The third vote was for children 2 through 18 years of age with any risk conditions if they've completed their conjugate pneumococcal vaccine by the time they reach 6 years of age. In those situations, if one of one or more of the doses they've received was PCV20, then they're done. There's nothing more to do. On the other hand, if they have not received PCV20, but have received 13 or 15, then you have a choice. You can either give a dose of PCV20, or you can give a dose of PPSV23, the polysaccharide vaccine, using the previously recommended dosing and scheduling. So they need a dose of 20, or if they only have 15 or 13, they either need a dose of 20 or they need the PPSV23 during this age range. And I'll mention as well, if they get PPSV23, you're supposed to repeat it 5 years later, but you're not supposed to get more than 2 doses of PPSV23 in your lifetime. And that's not new. That's a longstanding recommendation. And then the final vote is for children 6 through 18 years of age with any risk condition who have not received a prior dose of conjugate pneumococcal vaccine. For those patients, they've not received 13, 15, or 20, because that's the group we're talking about. They should get either a single dose of 15 or a single dose of 20. If 15 is used, then it should be followed at least 8 weeks later by that polysaccharide vaccine. So 20 alone or 15 plus PPSV23 in this kind of a situation. And same thing as before, you repeat the PPSV23 dose 5 years later, if that's the way that you choose to go. There will be clinical guidance. I'm not going to spend time going through them, but it'll be, what do you do when they've had PCV13 and they're still under 6 years of age? What do you do if they're 6 through 18 and have received only PCV13? And then there's a lengthy thing for stem cell transplant patients that probably is mostly for the hem-onc folks and the Feeds ID folks, but there'll be a lot of guidance here about how to actually do this and what constitutes catch-up and so on and so forth. All right, now let's shift to polio. Who would have thought we'd be talking about that? Good news, the type 2 polio virus has been eradicated from the world. And that occurred in 2016. And that really is remarkable news. I mean, it's like smallpox, and like I think there's a cow virus as well that's been eradicated. So those are good news situations. We do still have a vaccine-derived type 2 polio that circulates. That's shown in the green dots on this world map, and this listing in green that probably is too small to see on your computer screen. What we really are looking at right now are those green dots plus the wild type polio type 1 cases that are occurring in a small area in sub-Saharan Africa and the coast thereof, and then up along the Pakistan-Afghanistan border. That's where we just can't quite get ahead of this to get it totally wiped out. Now, a couple other points, that because type 2 was eradicated, and because we wanted to make sure we don't drive additional vaccine-derived type 2 polio cases, that has been removed from the OPV. So instead of a trivalent OPV 1, 2, and 3, we now have a bivalent OPV. We don't use it in the US, but around the world they're using it, and that's 1 and 3. Here in the US, we use IPV, and many other countries do as well, but it does not provide as good gut immunity as does oral polio vaccine, and that's why OPV continues to be the vaccine of choice as we push to eradicate these remaining cases from around the world. Now, why are we talking about this? Well, just about a year ago, there was a case of a paralytic polio in a young man in Rockland County, New York. And it was the vaccine-derived poliovirus type 2. Genetic sequencing linked it to wastewater isolates in Israel and the United Kingdom and in Canada. And it's important because in Rockland County, they do not have good polio vaccine coverage rates. Overall, children under 2 years of age, only 60% had received 3 doses. And in some zip codes, as few as 1 in 3 children had been fully vaccinated for poliovirus. Looking at the linkage between this type 2 polio and wastewater samples, it appears that this had been circulating as early as April of last year. And because there was a single paralytic case, the calculations are that at least 1,000 up to 2,000 people had actually been infected with it and had mostly asymptomatic, but maybe some mild GI symptoms, as we know polio does. But that's the kind of numbers granted, the largest city in the country, but that's the kind of numbers we're looking at simply by this importation of this polio case. So the ACIP has been looking at this. There's a slide here that shows who needs additional polio vaccine, those who are unvaccinated or incompletely vaccinated. But in general, adults are assumed to have been immunized unless there's some specific data to the contrary. Previously immunized adults at increased risk, and that'll be listed below, may get a one-time IPV booster dose, and that would include people who are traveling to countries at risk. If you're a healthcare worker who handles specimens or a laboratory worker who handles specimens, if you're a healthcare worker exposed to somebody or one or more patients with polio, parents of children who receive OPV, or if you're living in a community where polio is known to be circulating. There is a definition that I think is important about what is a fully vaccinated person with polio. That is someone who has completed the primary series and they were administered 4 weeks or more apart. And that primary series is with IPV, which is what we use in the US, or the trivalent OPV, if they're from other parts of the world. And last dose was on or after 4th birthday, and last dose was given 6 months or more after the previous dose. The ACIP vote on this occurred at the June meeting. It was an active meeting. Adults 18 years of age and over who were known to, or suspected to be unvaccinated or completely vaccinated should complete the primary series. Adults who have completed the primary series with IPV or the trivalent oral in any combination thereof, and who are at increased risk, the listing we just had before, may receive another dose of IPV, and available data don't indicate that they need more than a single lifetime booster dose if they do get it. Now, let's move to another area where there's not change immediate. Well, there's not change right now, but it's pretty imminently in front of us that we're going to see developments in prevention of RSV for the first time ever. This is really, really exciting stuff, although there's going to be complexity added in, as you'll see over these next several slides. So RSV has 11 viral proteins. There's a type A and a type B. The main ones we need to think about are the fusion protein, the F protein, and the attachment protein, or the G protein. Those are the main targets of neutralizing antibodies that protect against RSV infection or RSV disease. And vaccines have been developed or are in development process that target either F alone or both F and G. Now, an important thing to keep in mind is that the F protein has a pre-fusion state or configuration and a post-fusion state or configuration. And this is what it actually looks like. This is like an electron microscopy of what that protein looks like in pre and post-fusion. The immune system sees the pre-fusion form. Now, if you're old enough like me, you will remember that there was a vaccine for RSV back in the 1960s. It was a formalin inactivated vaccine. And not only did it not work, but it actually made the next season's acquisition of RSV worse. So that, put on ice for 50 years plus any RSV vaccine development. We now know why. Formalin inactivated means that it was the post-fusion state. So it wasn't going to work because that isn't what the immune system sees. And actually it primed the immune system for an overreaction when in fact it does see RSV. Now that's not the case with the newer vaccines, but it is interesting historically to tie all that together as to what we now know from a molecular standpoint and why it's relevant. This is a slide that is, I think, just kind of blur your eyes here and look at how much is on this slide. This is the pipeline, preclinical through phase 3, and those that have received market approval anywhere in the world, somewhere in the world. for live attenuated vaccines, protein-based non-live vaccines, nucleic acid non-live vaccines, recombinant vectors, and monoclonal antibody immunoprophylaxis. And I draw your attention to a couple of things. There is a Pfizer RSV vaccine. We're going to spend some time talking about that, about using it in pregnant women to generate an immune response in the pregnant woman that then crosses the placenta, the antibodies do, and they tank up the baby and protect the baby, much like we do with, Tdap during pregnancy for pertussis antibody, or with influenza vaccine during pregnancy to protect the newborn against flu. Now, GSK also had a vaccine that was discontinued. You'll hear more about that in just a moment. In addition, nirsevimab is a new long-acting monoclonal antibody. You can give it once, and it will last in the baby's blood throughout the entire 6 months of RSV season or potential RSV season. And it as well is both that and the Pfizer vaccine, maternal Pfizer vaccine, are coming along quickly in terms of FDA approval. So let's talk a little about that. We're going to start with the vaccine one. This is the Pfizer maternal vaccine. It's got this weird RSV pre-F terminology. And these are the numbers of cases and percent of cases for the women getting RSV vaccine in the latter part of pregnancy versus the women in the randomized controlled trial who got placebo, and the amount of time after birth within the first 90 days, or I should say 90 days after, 120 days after, 150 days after, and a full 6 months after. This is protection against severe lower respiratory tract disease in the baby. So this is the baby's RSV severe disease. That's equivalent to being admitted to the hospital. And we have about 80% vaccine efficacy at 3 months. It does drop down to about 70% across the 3 month to 6 month time frame, but a nice vaccine efficacy here. Now, the same sort of thing, but looking at medically attended RSV disease, but not necessarily severe, vaccine efficacy is in the 50 to 60% range. Again, very similar to what we see with influenza. These numbers are influenza vaccine. So this would suggest that, hey, this is a good thing. You can give this vaccine to moms and you can protect the newborn. And this shows why that is. On this slide, you've got in blue the antibody titers in the babies following delivery, month 0, month 1, 2, and so forth, out to month 6. The red dashed line is what we know to be a threshold above which, if a baby gets palivizumab, they have protection. And so it suggests that the reason we see benefit is because the antibody concentrations against RSV during that 6 month period exceed the minimum threshold of palivizumab to be effective. Now, it's just a comparison. They're not getting palivizumab, but it's just a comparison to show these antibody titers. But here's the catch, and we don't know what this means. There were more preterm deliveries, preterm births among women who received the vaccine during pregnancy versus those that got the placebo. And it was not statistically significant. It was not statistically significant. But you can see overall 5.7% versus 4.7% with overlapping confidence intervals, hence not statistically significant. And then if you dig down into this a little more, it was not the within 7 days or within the first month of getting the vaccine where there was an increased likelihood of preterm delivery. Instead, it was more than a month after the vaccine was administered, which really doesn't make a lot of sense for it being a real effect, something really that's being caused here. And in addition, it was seen in South Africa, but not elsewhere. If you look at the distribution of preterm deliveries by gestational age in the U.S., these numbers are percentages are very, and numbers as well, are very well balanced. It was in South Africa where this was seen. So people are scratching their heads and going, does this mean anything or not? Where it catches a little bit more attention with folks is because I mentioned that GSK vaccine that was stopped, that was discontinued. Well, in the GSK phase 3 study, they also saw a higher percentage of preterm deliveries, and it did reach statistical significance. This is not understood. GSK doesn't know. They're still looking into why it happened. Might have been a fluke. It might have just been chance, but it does give people some hopes. Now, a little bit on nirsevimab. This is the monoclonal antibody, if you will, kind of a souped up palivizumab or Synagis. It is high potency, and it has a very long half-life, so you can give a single dose across the RSV season. There were 3 studies that were done. There was a phase 3 and a phase 2b, where the comparator was a placebo because the group that was receiving or enrolling, I should say, on the study was not recommended to receive palivizumab. And then there was a phase 2-3 study where it included patients that would qualify for palivizumab, so it would be unethical to give a placebo. And in those situations, it was nirsevimab versus palivizumab. So this is just kind of an outline of the different kinds of studies that were done with nirsevimab. And this is a summary of what we saw. Medically attended RSV, lower respiratory tract disease, hospitalization, ICU admissions. You see, you can work your way down, and you're in about the 80 or 90% range in terms of prevention, the vaccine or the passive immunization efficacy. So very similar to what was seen with the RSV maternal vaccine. And the cost effectiveness analyses look pretty good too. And no one really sets a hard limit, but generally speaking, if it's $100,000 per quality adjusted life year, that's probably a good investment. Best would be $0 because then it's cost savings, but that doesn't really happen very often. And you can see that it's going to be highly dependent on what the nirsevimab cost is. But it potentially could be in that $60,000 to $100,000 range for quality range, which would make it, a good investment. But everybody's kind of waiting with pins and needles to see what happens in terms of once nirsevimab is approved, and I think it will be, what that dose is going to be. So some possible recommendations might be to immunize mothers at 24 to 36 weeks, although there was at the ACIP meeting in June, some people advocating for a much tighter window of 32 to 34 weeks, because then you don't have to worry as much about the preterm deliveries if there is such an association. So yet to be kind of debated and talked through all the way. And then if a mom does not get the vaccine, then nirsevimab would be administered to all the newborns of those women, or if the woman's vaccine was 2 weeks or less before delivery, and therefore you couldn't really count on good antibody response and transplacental passage, that baby would get nirsevimab, or maybe if they're before 28 weeks where you don't really have good, reliable transplacental passage of antibody in the first place. And they're looking at different times, and probably, even though there are no data, probably nirsevimab will end up being recommended in the same population for season 2 as palivizumab currently is being recommended. My guess is this is not going to happen fast enough for this to have a major impact anyway for this upcoming season. There are issues about nirsevimab and whether it would qualify under vaccine for children, for example, and there's, they both just have to be approved for pregnant women for the vaccine and nirsevimab for the babies. But be watching, because there will be some activity here, I bet, before we get to September, October, and then we'll try to figure out what to do in terms of these recommendations. Now let's finish with some brief conversation about meningococcal vaccine. There are 5 of them: Menactra, Menveo, and Menquadfi. Menquadfi and Menactra are made by the same company, so Menactra is going away, and we'll be left with Menveo and Menquadfi. That's for ACWY coverage. And we have 2 B vaccines, Tremenba and Vexero. Now, note that the recommendations for use, this is in high-risk groups, for ACWY is beginning at 2 months of age with the age-appropriate vaccine. And for Men B, it's 10 years of age and over. There is not a recommendation, and people in the US are not looking at having a recommendation right now anyway, for people under 10 years of age for meningococcal B vaccine. Now, it's confusing to everybody. Where did meninge go? When I was training in the late 80s, early 90s, it wasn't common, but it was a dreaded, horrible disease. And really, before we even had the MenACWY vaccine in 2005 or the Men-B vaccine in 2015, the overall incidence of meningococcal cases had fallen dramatically, and no one knows why. But we are really at pretty historic low levels of meningococcal disease, maybe being kept down by the vaccine, maybe something other is going on. We don't know. This slide shows 2010s versus the very first part of the 2020s. It's the same y-axis, the incidence per 100,000 going up to 1.4. And look how much lower the bars are. And also look how much of the bars are B for all these years in the prior to 10 years of age, which is the group we might give a MenB vaccine to. So it's really confusing as to what to do with these. But in the face of all of this, there are pentavalent vaccines that combine ACWY and B. So you would have a MenABCWY vaccine. Both GSK and Pfizer are developing these, and we may have some data by the end of this calendar year. So the question is how many doses to give, what would the impact be, and so forth. And so I'm going to close with this last slide, which shows what might be possible meningococcal vaccine approaches. And these are just a bunch, this is just beginning to be debated. The one possibility is to give MenACWY at 11 to 12, like you're doing now, and then give MenABCWY at 16. And then the second MenB dose would be with MenB. But that would require you to stock for 3 vaccines, the MenACWY, the pentavalent, and a single valent MenB. That was discussed at the meeting, and that was a big criticism that a lot of the ACIP members had. So another thing that was brought up, and I think this could be intriguing, would be to forego the 11-12 dose and instead use MenABCWY at 16 years of age for both of the doses at 16 years of age. So not clear what's going to happen, but there will be maybe over the next year and a half, some recommendation changes. So in summary, we're still behind nationally on routine immunizations, and we still have significant disparities. There will be big changes with pneumococcal active vaccine and passive and active and RSV passive and active vaccine recommendations. Meninge vaccine recommendations are complex still, but there might be new opportunities to look at ways to make them simpler. And the return of polio shows the threats that we still face. So with that, I'm going to turn it back to Mina and see if she would like to see if we have any questions.
So thank you so much, Dr. Kimberlin. I want to remind everyone, you can ask your questions. You can drop them in the Q&A box or in the chat. We do have one question that came in asking, several vaccines are given at 2 months of age. Are these vaccines given on the same day? Are they staggered? Do routes and sites differ? So could you speak to that?
Yes, it's a very good question. The standing recommendation is, with very few exceptions, there are 3 maybe exceptions, but the recommendation is to give all vaccines that are due on the same day. Now they might go in different legs, or in the same leg separated by an inch or more. But if you have an opportunity to vaccinate, use that opportunity. That goes for adults as well. It'll be interesting in the adult world how they've got moving parts here. They've got the 20-valent pneumococcal vaccine. They've got the new RSV vaccine, which is for older adults, and they've got COVID and flu. So the adult world's debating, do we want to give all 4 of those at the same time? Do we want to, because we don't have a lot with those examples. We don't necessarily have a lot of data about multiple administrations. And so some people are taking the argument that I just made that, give it while you can. And others are saying, well, let's go a little slower. Let's prioritize COVID and flu, for example, and then based on age, whether to give RSV and pneumococcal. Again, that's for the other end of the age spectrum than what we talked about here.
Please feel free to drop any additional questions. That's the only question that I've seen so far. I know there was some discussion earlier on when you were discussing MMR vaccines and the different routes and the different types of vaccines. So there was some good discussion happening in the chat. Let me see. A question just came in. What can be done to address the ongoing vaccine hesitancy?
Well, the American Academy of Pediatrics is in the very, very final stages of issuing a clinical report that is it's going to continue to address, kind of update recommendations for how to talk with families, parents about vaccines. And it really is a very useful document. Sean O'Leary's chair of the Red Book Committee, the Committee on Infectious Diseases for the AAP at University of Colorado, and he does, that's what his area is vaccine communication. And it's really some very sophisticated social science kind of work, where you bring in small groups, or you do these sophisticated surveys, and you try to find how to make it happen. One thing I would strongly encourage is when you go in to talk with a family, or visit with your own family members, recommend it. Don't equivocate. Don't say, well, you can think about it, blah blah blah. Instead, say, look, I really believe in these vaccines, and I definitely think you ought to do that. Or if you are a healthcare provider, when you go in, you don't say, do you want to get your vaccines today? You say, you're due for these vaccines. We'll give them here in just a minute. Do you have any questions? Make it like that. And is that maternalistic and paternalistic? Maybe. I don't know. But I do know that if you don't do it and the child doesn't get vaccinated, they're at risk of dying. And these are very safe and effective vaccines, all the ones on the vaccine schedule. So I think that shared clinical decision making is all well and good, but if somebody says no, you can't do it, you're not gonna hit them in the face and give the vaccine. You're gonna respect their wishes and continue a dialogue with them, but don't make it easy for them to say no, because this is the best thing for their child, undoubtedly.
Excellent. Related to the previous question, someone asked, are there any vaccines that cannot be given in the same limb for children and or adults?
Yes, and I'm not gonna say that about that more, because I'm not gonna trust my memory. There is a meninge Tdap, min ACWY, not Tdap, min ACWY DTaP issue, and that's where Menveo has to be the meningococcal vaccine to use. And then there's one or two other things with pneumococcal conjugate vaccine and DTaP as well, where there have to be separation between. But all of that is in the vaccine schedule and the general recommendations from the ACIP, and in the AAP Red Book and other AAP recommendations.
So utilize those sources, those resources. There's several people who are asking questions about why Menactra was discontinued and going off the market. Can you speak to that?
Yes. Well, of course, I'm not on the inside with the company or anything, but the newer conjugate min ACWY conjugate vaccine that's been on the market for 2 years and over is the new version, if you will, of Menactra. And the reason Menactra did not really get the traction is what I just said about that inability, because of what it's conjugated to. The DTaP vaccine and Menactra couldn't be given because it could interfere with the response to DTaP, if I remember correctly. And so Menveo kind of had a lock on that 2-month market, 2 months through 1 year, so 2 months to 2 year market anyway. And so that's when they said, well, we're just going to forego the Menactra. It was not a safety issue or an efficacy issue with Menactra by itself, but it was an interaction with a different vaccine. It also was needed to be given to those young infants.
Another vaccine that someone has a question about is there any data regarding the use of Vaxelis? Any concerns with this vaccine?
Vaxelis is a multivalent vaccine, and the only thing that I can think of right offhand is it is not for Native American and Alaska Native populations. It is not recommended to be the the vaccine that's initially used for Haemophilus influenza type B. And it may be found to boost up the antibody titers most quickly, but we still have, one vaccine, one of the HIV vaccines that is preferred in that population. Beyond that, everything's interchangeable. The standard thinking and recommendation from AAP and CDC is, in general, combination vaccines are preferred over, individual vaccines, which of course is the comparison, it's not against individuals. But the idea is the fewer sticks, the better, because that can be a reason for vaccine hesitancy. And also pain and discomfort. So, let's try to minimize that if possible.
Another question, is there an advantage to the patient for more than one nurse to simultaneously administer the shots, right? Thinking, is that less traumatic or traumatizing for a child?
So in other words, what I'm hearing you say there is, two nurses giving vaccines simultaneously?
Correct.
I do pediatric infectious diseases, and the experience I have with giving vaccines is watching them being given to my own children. So I'm not going to be the best one to answer that question. I have seen, kind of paired up approaches like that. I've also seen where everything is set, the different vaccine needles and so forth are set up here, and it's just one after the next. The gist here is to do it fast and to give the most painful one last. And so if it can be done with two, there's no, to my knowledge anyway, no reason not to do it that way. It does tie up some staffing in the clinic. So I'm sure there's more to it than I realized in that regard.
Good points. I think we have time for one last question. Do you anticipate any insurance pushback for the RSV vaccine? Prenatally, this person wrote, one of the most frustrating challenges historically has been the approval of Synagis.
Yes. Synagis is palivizumab, so that's a monoclonal antibody. In terms of the vaccine, that's what the mom would get. That Pfizer product. I doubt it. It's a standard vaccine. I know it'll take a while to work through the system and so forth. And that's the reason I don't, we were all kind of hopeful that this 2023 RSV season would be majorly impacted by these new preventative options that we have. And now we're getting a lot less confident in that. I think we got to work through with the pregnant woman vaccine. Does it really cause premature birth? How do we value that? Is it just a weird signal that's not real? Do we narrow the window to give it? I mean, there's a lot of those questions that are being worked through, as we talked about earlier. But I still think when it does become available, whatever the recommendations are, the authorization of it by insurance companies will be pretty standard, I would expect. Now, nirsevimab is a different matter. Earlier at one of the ACIP meetings, you may remember the cost effectiveness slide. There were several rows where nirsevimab was priced at $300. The word is now that it may be up around $500. That's still a whole lot less than $1,600 per dose of palivizumab. And you got 5 doses potentially. So this is a still markedly less expensive vaccine. I'm sorry, passive immunization. But the catch is that right now it's being, as I understand it, it's going to be approved by CDER, the drug portion of the FDA, rather than CBER, which is where the vaccines are approved. And then the safety mechanisms will be through CDER. That's FAERS instead of FAERS for vaccine surveillance, safety surveillance under the vaccine, the biologics portion of FDA, and it might not be covered by Vaccine for Children, and that could have some real equity issues. So there's a lot of this that has a lot of people concerned, not about the benefit of it, but how is it going to roll out? And my guess is it's going to take some time for nirsevimab especially to have those things work through.
I know we're at the top of the hour. We have one more question, Dr. Kimberlin. Do you have time to answer one more?
I'll make it quick, I promise.
Perfect. Are there any new methods of vaccine delivery being considered by the ACIP that may be less painful or improve delivery?
Not that I know of.
Okay.
Now, I will say that there are several COVID vaccine products in development. They're not approved yet, to my knowledge, anywhere, but that are nasal vaccines. And then there are some vaccines in development that are transdermal vaccines or little microneedles, but nothing that's far enough along that ACIP or AAP, for that matter, are really talking, actively about.
Well, that wraps everything up. Dr. Kimberlin, I want to thank you again for joining us for this hour, for this very informative presentation. I've learned a lot, and I know our audience has as well.
Well, I really appreciate the opportunity to be with you today, and I thank everybody out there for the fantastic work that you're doing.
Yeah.
Vaccines save lives. Vaccines save lives. I mean, that's the message, and y'all are the messenger. Y'all are the trusted messenger that the parents listen to their pediatricians and their healthcare providers overwhelmingly. So you have power, and we really, really appreciate everything you're doing. My own children are getting to the age where they might have kids of their own. I appreciate it, personally. And so if there's anything that we in infectious diseases or UAB, writ large can be of help with, don't ever hesitate to reach out. We're happy to do whatever we can.
And thank you to everyone who has joined. As a reminder, all registrants will receive an email within 1 week of the webinar with a link to this recording, the slides if you didn't grab them earlier on in the presentation, and the evaluation. Thank you again and have a wonderful day.